We are going to be talking about the fentanyl and overdose crisis happening specifically in rural America. And we have several great panelists. I'm eager to get to them. We have Regina LaBelle, and when they pop on, I'll have them introduce themselves, but a little bit of background. She is a distinguished scholar and director of the Addiction and Public Policy Initiative at the O'Neill Institute for National and Global Law at Georgetown University Law Center. Let's see. And then we have Dale King and we have Lisa Bright. Lisa, do you want to introduce yourself real quick?
Sure, I'd be happy to. First of all, thank you for having me today. My name is Lisa Bright. We have a foundation called the Will Bright Foundation, where we serve men coming out of recovery needing help with those next steps: housing, transportation, job placement, that type of thing. The foundation is named after my son, Will, who we lost to a heroin overdose in 2012. So our nonprofit is in memory of him and serving a lot of people in the West Alabama area.
Well, I'm really sorry about your loss, but what a great, in memory of him, great opportunity to speak on this. So thank you for being here.
Thank you.
Regina, I introduced you a little bit before you hopped on here. You want to talk a little bit more about your background and what you do at the O'Neill Institute?
Sure. Thanks for having us here today. My name is Regina LaBelle. I am a professor and director of the Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown Law. I'm an attorney by training, but my background has been in public service for a number of years. I served both in the Obama administration in the White House Office of National Drug Control Policy, as well as in the first year of the Biden administration, working on, I was the acting director working on reducing the nation's addiction epidemic. So thanks very much for having me here today.
Yeah, thank you. And thank you for all your work. And before we get to Dale, I believe we have a trailer that we're about to watch.
Since 2007, the leading cause of accidental death in Ohio has been overdose.
149 pills for every man, woman, and child in the county. And I did a lot of them.
Spent 2 deployments to Iraq and then came back home to a town I didn't even really recognize. It was ravaged by an opioid epidemic.
Yeah, this looks about as sketchy as you described it.
Portsmouth, Ohio had the highest per capita pain clinics in the country.
There's nothing on the street today that doesn't have fentanyl in it.
You can't put anything in your mouth. It doesn't come directly from the pharmacy.
People had surrendered to this enemy, and there was no one willing to fight back.
At some point in your life, you weren't afraid to die. Don't be afraid to live right now.
This is hillbilly rehab.
Exercise has clearly been identified as a tool that can be used in the recovery process.
We've got everybody from addicts to immigrants. We all need a challenge, and we all need the ability to overcome.
What we're trying to do is a very aggressive kind of approach. We're just trying to do it better.
That's the biggest thing that we do here. We give people an opportunity to earn.
I've probably spent over 1.5 years incarcerated. My last class, Dale comes up to me and was like, hey, why don't you come work for me?
With the right training, we can have a big role in bringing American manufacturing supply back to small towns.
Now you got some confidence, now you think you can overcome anything. It's very easy to relapse.
He was flying too close to the sun.
He started to become someone else.
This affects everybody.
We want to tell everybody, and maybe you don't have to go through what we went through.
Go!
There's a lot of good going on in this town, and it's because there are people that care about this community.
Come on, Sarah. You've been here before.
It's not just, we got an addict on our team. No, Sarah's on my team. I'm a person.
If there's anything we know, it's suffering. But because you know suffering, you know how you can heal. It's time for a comeback.
Oh man, that gives me chills. Dale, welcome. Do you want to introduce yourself outside of the documentary?
Yeah, thanks. Appreciate you guys having me. So from the documentary film Small Town Strong, And it basically kind of chronicles the story of our small town here in Southern Ohio, Portsmouth, and then the work that we're attempting to do by adding fitness as a force multiplier to traditional counseling and recovery, and then on the back end, getting people healthy and sober, and then helping them either find economic opportunities through businesses that we own, or just trying to get them find their path in life to long-term recovery.
That's amazing. Just so honored to be with you three and you guys doing the Lord's work. I have my first question, but before I do it, I just want to let folks who are viewing this, you can put questions in the Q&A, not the chat, but the Q&A section, and we can get to all of them as they come. But the first question, I want to start off on a little bit of a more positive note. The CDC recently reported that last year, for the first time since 2018, opioid overdose deaths have declined. Now, I want to ask all three, but I'll start with Regina. Do you think this is finally we turned the corner on this, or what do you think is happening?
Thanks for asking that question. We've been here before. In 2018, there was a slight dip. I thought then, and I think now, that it's way too soon. We don't know. 1 year is not a trend necessarily. And I also think, I just was at the Canadian Embassy speaking about this issue, and, Canada's going through a lot of similar issues. But I cited the fact that in a 10-year period, a recent study just came out that 312,000 children lost a parent to an overdose. So while even if the numbers come down, we've got this huge bow wave. That's, people who have lost parents, and that's not going away anytime soon. So while, good news, it didn't go up, I think it's way too soon.
Yeah. How about Lisa? What are you seeing in Western Alabama?
Well, we're not necessarily seeing that trend in the rural. We're in a very rural part of Alabama, and we're still seeing a lot of overdoses, unfortunately. Now, some may not be as related to opioid as they are from the symptoms that opioids have caused. So we're not really seeing that. I think of some classic stories on that is that as we've done some good things, we really have. We've made some good moves in the legislation and other pieces, but the medical industry, I think, is a little far behind. I work with the group that we try to get legislation passed, and that's pretty unanimous understanding that some doctors, especially that went to medical school a long time ago, just aren't maybe as current and up to date on what the prescribing procedures should be. My husband just had foot surgery, and he wanted to get the shot that would numb his foot for like up to 72 hours. Well, to get that, first of all, we had to pay for it, but we're working on that. And second of all, we had to go to another pharmacy, keep it cold, and bring it to my provider that was going to do the surgery. That it's getting there, but it still has a long way to go. When you've got to go through those many steps just to be able to go the non-opioid route, we've still got some work to do.
Yeah. Dale, how about what are you seeing in Ohio?
Yeah, I mean, I would say I hope so, but just because the numbers are so staggeringly high. That eventually we need to stop the bleeding, figuratively and metaphorically. But I agree. Like I'd like to see at least 3 to 5 years to really notice the trend. But just looking at the overall atmospherics, you really can't tell a difference. So I'm hopeful. There's a lot of good work being done, but I need to see at least 2 to 3 or 4 years worth of data to show a decline.
And how long have you done your gym as part of recovery?
Yeah, so the gym's been in existence since 2010, but we've really focused with folks in recovery since 2018. So we kind of started right at the peak of all the overdose deaths.
Okay, that's good to know. Lisa, what do you think are the key demographics that are most affected?
What we see here in Alabama is primarily those in rural and just the underserved. So those that don't have access to any kind of health care. So they're going to get a lot just off the street. if that's what they need. But I feel like those are the two biggest demographics here. I work with Appalachian Regional Commission on a lot of work in the opioid space, and we see the hot pockets are typically in your rural parts of your state.
Yeah, and Regina, is that nationally too, kind of the same trends, or?
Huge access issues, access to treatment, access to transportation, et cetera, in rural areas that exacerbate, these issues. What we're seeing right now in terms of the trend for overdose deaths are disproportionate increases among Black American communities, nationwide, as well as American Indian and Alaska Natives. So American Indian and Alaska Natives clearly in rural areas, primarily in rural areas. So that's what national trends are. Those are showing disproportionate rates of overdose death.
And Dale, how, like, shifting the culture on this issue, like you encouraging people who are struggling with addiction to ask for help or accept help. What have you kind of seen and deal with that on a day-to-day basis?
Yeah, it's kind of difficult because the people, as far as going back to the demographic question, I'd say overall it's a poverty issue is number one. And then two, what a lot of people don't really factor in is it's generational. This problem really, unfortunately, we started the pill mill business model here in Portsmouth back in the mid 90s. So now you're coming up on children being raised by addicted parents. And so now it's not only those who are economically depressed, but now it's a generational thing as well. So it's just getting people to kind of break through the stigma, and kind of break out of the shame and isolation to know that, hey, this doesn't need to define you as a person, and there's alternatives out there that you can seek to kind of help regain your life.
Yeah, and how did you come up with, or how did the documentary come about?
It's a long story, but I'll try to make it short. The guy who, a really good friend of mine, he was a member here at my gym, and he said, "Hey, I want you to know the gym's been really instrumental in my own personal recovery, and I'm taking a position at a local nonprofit treatment center, and I'd like for us to figure out a way that the gym does classes at the treatment center." I had no idea that he was in recovery as well. And so I said, "Yeah, man, let's do it." Having no background in addiction treatment, counseling whatsoever. And for me personally, I had kind of the standard small town negative viewpoint on people with addiction, that it was their fault and they were weak-willed or weak-minded, and they were kind of the mascot for the downfall and decline of our town. But it wasn't until I began to, it's funny how it works when you actually have a conversation with somebody. You can learn about where they're coming from, and just hearing the horrific stories of how they fell into addiction. Primarily trauma based or generationally, and it really kind of shook me to the core on what this problem is, and how, to me, it's the number one, not only healthcare issue, but it's really kind of becoming a national security issue as well, facing our country. But we began to get a lot of positive press from it. We were on the Today Show, Rolling Stone, and a couple other outlets. And then an individual had the idea to develop a series for it. And so we said, okay, but unfortunately during filming, my friend who started the whole program, he relapsed and died of an overdose. And that was in 2021. And we got tired of striking out at the studios and the streamers, and we wanted to honor him and get his story told. So we independently financed it and produced it and got it out there.
Wow. Lisa, I wanted to ask you about the cultural shift. Have you seen that change through the years?
Well, I have. I've seen it for the good and I've seen it for the bad. I think the culture has gotten better in some ways where it is more understood than it was when my son started going through this in probably the mid to late 90s. It was just taboo if you had a child that was in drug addiction, that you just must be a bad parent. We don't have a history of that in our family, so it was just very hard to walk through. So from that respect, I think more of this type programming, what you are doing right here, and working more with your departments of mental health and your Department of Justice on trying to get better pathways for people to follow has helped a lot. But there is still the stigma. I think we're still stuck in a lot of ways of the illegal drugs are just too easy to get. They're all laced with fentanyl, like the documentary said, and that's the scary part. Is so much of that we can't control, and so it's a mix of both. I think we have seen a lot of good because people like us are getting in front of other people and telling their stories. Even though sometimes it's extremely hard to tell, you have to do it because you got to save lives, and I think that's the best way to get the messaging across.
Yeah, I'm going to ask all three of you this question, but I'll start with Regina. What steps can be taken to mitigate the risk factor?
Risk for developing a substance use, or
yeah, just kind of what we're seeing, what has worked in communities, and just. I mean, again, we've had last year was a downtick, but what can we do to increase that downtick?
Sure. So, I mean, first of all, I think you all are a really good example of one of the things that has to happen. So, is to speak out. And I have so much appreciation for people in recovery and also people who have lost loved ones to speak out. And I have tried to support that work in every way I can. At Georgetown, I hire people in recovery. I teach students in recovery. I've had students come up to me and ask me if it's okay that they talk about their recovery. And I want them to. They need to be part of the solution. So, breaking that stigma is really essential. The second piece, I work in Washington, D.C., and I've worked on national issues for a long time. But really, the solutions lie in the community support. So community work, it has to be one-on-one. And there's a saying that the opposite of addiction is connection, and those connections come from community. And I think I am so always overwhelmed by the community that surrounds that's essential to a life in recovery, and that development and that connection. So while there's lots of things that DC tries to do. When I was in the administration, we tried to remove barriers to treatment, et cetera. But really, it all relies and comes down to removing stigma, to supporting families and communities, and families in whatever way that's defined. But community work first and foremost, and supporting those individuals to break down stigma and build community.
Yeah, and I want to I'll put a pin in asking you about your time in the administration and kind of what you've seen from the federal standpoint in a little bit, but I want to get to the rest of them on this question. So Lisa, I'll what are some things that we can be doing to mitigate the risk factor?
I agree with Regina on the fact of community. Community is huge in the recovery life. We are very blessed to be with the Will Bright Foundation. Our transitional living facility is called Restoration Springs, and we're in Fayette, Alabama. And it is a wonderful community that supports us. We support them. We volunteer for projects. We're even having a big aquatics day where we just invited the community to the local aquatic park, and just a day to celebrate recovery. But I think something we can do a little bit more on is the preventative side, and that's going to have to start a lot younger than middle school and high school. You're really going to have to dig deep into the elementary age students. So I think the awareness and prevention is going to really have to step up, because as someone said earlier, kids are being raised they've been raised by their drug addicted parents, so they don't know the difference. And if there's more programming, I believe, in schools where that city and that school system can partner better, spend opioid lawsuit monies better, and be able to promote more programming or programming period for students that are coming up, I think that would be a huge curve in the addiction overdose race.
Yeah, and Dale, what do you think we can be doing to mitigate the risk factors?
Yeah, I mean, I would absolutely echo the other two ladies' sentiments. For us, it's a matter of creating opportunities for commonality, because what we see here is recovery a lot of times exists in bubbles, and it doesn't necessarily bleed over into the overall bigger community, and vice versa. So one thing that we're trying to bring about this year is invite people in, like, we have a thing where we have people in recovery and police officers that come together and work out. So we put everybody on different teams, put them through a good workout, and then at the end they all sit down and talk about their experiences with addiction. And what we found so far is, you would expect, the vulnerability and being honest from folks in recovery, but typically the stories from the police officers are just as heartbreaking and heart-wrenching as well. So it's bringing different people from the community together to understand that we're all in this problem together, and it's not a them problem, it's a us solution.
All three of what you had to say, I think, is just so it hits home with me here in Sioux City, Iowa, as it does in Ohio, Alabama, and elsewhere. So, Regina, you have a very impressive background. So this is what do you want to talk a little bit? You worked in 2 different administrations on this at the federal level. Can you talk a little bit about your time working there and let folks know your roles in the past?
Sure. So in the Obama administration, I worked for, I was the chief of staff to our then director, Gil Kurlikowski. So Gil Kurlikowski was a police chief who came into that position and kind of acted as a bridge to our next director, who I also worked for, who was a person in long-term recovery. He was very public about his recovery. He was public about the fact that he was arrested for driving while intoxicated. It opened up such a window and such an opportunity for people to come forward. Staffing him was really interesting because there were so many people in recovery who wanted to just be near him. And it was so moving. And it was, I think, it was really the beginning of this national recovery movement. And people coming out of the shadows and saying, really, really raising their hand and saying, this affected me as well. And then also parents as well. And then I went back to Georgetown, where I was really fortunate to start this master's program in addiction policy because, I'm an attorney. I learned on the job, and you shouldn't learn on the job. So people should, if they're going to do addiction policy, we need to treat it like it's a profession. And so I have my 3rd year of students who come from all over the country, and they're serving in nonprofit roles. They're ready. They're ready to hit the ground running. They work in the federal government. And then the Biden administration, I was fortunate enough to be the acting director for the first year. And in that year, there were some things that I want to stress, this is a bipartisan issue. And while I was a politically appointed person, I worked across the aisle all the time with lots of rural legislators, lots of rural members of Congress, because this is not an issue that, escapes any one group. So in the Biden administration, we looked at what can we do. I had my 4 years in academia to kind of pick those things that we wanted to do once we got in the administration, and we were able to remove, barriers to fentanyl testing strips, to increase interventions for people who may be using drugs, so that we could meet them where they are and get them into treatment if they need it, deal with their homelessness issues, and get them other services that they might need. So those are, that's kind of a shorthand for the long period of time I was in the administration. And we didn't get in this issue overnight, and we're not going to get out of it overnight. So we've got a lot more work to do, obviously.
And what do you think one of the biggest hurdles of I wouldn't say solving the issue because we know how complicated things are, but like just to I guess go on this trend of turning that corner finally.
I think there are two things. The one that if I were still in the administration would keep me up at night is just the proliferation of synthetic drugs. We don't know what the next drug is going to be. It might not be fentanyl. You know, we're seeing xylazine, we're seeing other drugs. These are all chemically based. You can't fly over them and see them like we did with crops. So that is a really big issue. But the second challenge that we have is addressing those conditions like poverty and trauma and adverse childhood experiences that like lay the groundwork for later substance use disorder and youth substance use and later substance use disorder and untreated mental health conditions. So they go hand in hand, right? Making sure we're looking at the transnational aspect of this, as well as, you know, the community-based work that has to be done to make sure we have, you know, children who are not living in poverty being raised by people who may have untreated addiction, who aren't getting the help that they need.
So one of the things, I'm in the Iowa State House, and one of the things this legislative session we talked about was what to do with the opioid settlement. So I want to go around to all three. I'll start with Lisa. What do you think we should be doing to best utilize the opioid settlement funds?
Well, I can speak to that on a couple of different levels. So the first thing that comes to my mind is what I spoke on earlier is the prevention side, the awareness and prevention side, and getting that in our schools and doing better programming when it comes to that. The other side would be working with our facility being in a rural part of Alabama, being able to say maybe several cities or an entire county come together and come up with a project that together they would have more funding to do something that might be larger and longer lasting to help prevent opioid overdoses. And I think that's something that a lot of, I know in the state of Alabama that they're encouraging communities to do that. So, and you may only get, you know, I don't know, $100,000 if you're a super small city, but if you partnered with your sister cities or the whole county, you know, you may have a lot more money, and sometimes that goes further. So I think I'm also a city councilor here in Trussville, Alabama, where I live, and those are some things that we have looked at. And then, of course, your first responders, we have to take care of them when it comes to them walking into a position and they don't know what's been going on and what kind of, if there's fentanyl laced everywhere, that we have to make sure that they're taken care of as they try to protect our community. So I think those would be the three things that I would really hope that most communities would be very mindful when they get ready to spend those monies. They are one-time monies, but in the state of Alabama, it'll be over about a 10-year period. So it is an opportunity to make a huge difference if it's encouraged to spend the correct way.
Absolutely. Dale, what would you like to see with the funds?
Yeah, I would like to see innovative solutions to the problem and kind of take a look at what's working. And most importantly, we need to make sure the funds aren't squandered, you know, kind of like they were during the tobacco settlement days. But, you know, for example, one thing is if we keep talking about how community can help solve these, be a big solution to this problem is like, okay, then we need to create opportunities for community. And an easy way to do that is kind of at the county level, create community centers. You know, build them up, staff them up. And if this is a healthcare crisis, then we need to present opportunities to get people healthy. And then we can take people like the first responders and people in recovery and have access to preventative healthcare in the form of fitness and wellness, and tag on to some recovery and counseling as well to be able to be operated through those centers.
So I guess I want to focus on the process piece because I think that every state's going to be different, every county is going to be different. But first and foremost, look at where the gaps are and where do you really need the money to go. You know, where are you lacking, and where's the most urgent approach? So That's going to take a little time. And I know that people are really anxious to get the money, and I totally understand that. But people need to remember also this is supplemental money. It's supposed to supplement what the state's already doing and what counties are already doing. So, where are the gaps? Invest in that, in where the gaps are, and then make sure you evaluate whether or not something's working or if it's too soon. Because it's over, in most states, it's over now it'll be a 17-year period. But the other piece that we focus on quite a bit is transparency. So how is the money being spent, and how can people find out, and how can they know, how can they get involved? And not every state, county is necessarily having those community engagement processes by which people can find out where their money's going. And also to make sure that the money isn't squandered, you're going to need transparency. You're going to need, conflict of interest rules, all those things that are more process oriented, but set it up for success.
And do you have any advice for a state like Iowa as we try to figure out what we should be doing this?
We have lots of papers that we've written on this, and we try to keep everything to 1 or 2 pages. Conflict of interest policies, et cetera. So happy to share our our information with folks.
Would that be on O'Neill Institute website?
I can.
Okay.
Let me pull up the website. I can put it in.
Yeah, no worries. I just was curious, just in case, as like I come down the road, so I know a resource for it. So grateful for that work. So I think another aspect that I would like to talk about in this is the impact this epidemic has had on caregivers and what the role they play in assisting family members battling addiction and undergoing recovery. Lisa, start with you maybe. What do you see, because I see caregivers, we're having a caregiving crisis along with the amount of, or the lack thereof. We need to have more, but what do you see when it comes to opioid addiction, of what you see and what we need?
Sure. I had a feeling you'd come to me first.
Oh, sorry.
No, the caregivers, which, and to me, is the family members that just watch a family member just struggle and you don't know where to go. There is better resources now, I do believe, through, at least in the state of Alabama, we have the University of Alabama that is doing fantastic work with a program called Vital. They have created an app where you can easily go in and find a place for recovery or treatment, whichever you're wanting, which you need the clinical side. But it tears families apart. It really does. And when you're exasperated because you can't get the right help for your loved one, or they don't want it. And that's a whole nother part that we really haven't discussed as much, that we run into in the work that we do through the Will Bright Foundation, is you have some that just either aren't ready or they just don't want it. So the caregiver can just want to throw their hands up and walk away because it is truly exhausting. But I think having better resources where you have things at your fingertips. When we went through this with Will, 15 years ago, when he was really battling it hard, I didn't know where to go. Call, I don't know, who do you call? So having things like this where you've got options for people to go, oh, I remember she said something about a university that offered some programming, at least for resources. Our county here in Alabama, Jefferson County, has a great resource center as well that will help direct people, caregivers or ones that are in substance use disorder, a place to go, a phone number, just something. So I think it's gotten a lot better. It still has a lot of room to grow, but for caregivers themselves, just having more information readily available, and that's going to have to take place for people just being open and talking about it.
And you don't have to get into details or anything, but how did you know where to go?
I didn't.
Yeah.
So we had a local drug addiction, well, I wouldn't know a hospital, but a clinic here in the Birmingham area. And we went that route first, and that kind of connected us to some counseling. then we had some local faith-based recovery programs that were really, really good. So we just had to lean into what little we did know. And it started just because someone advertised on television, and that's not necessarily the best way to find out on how you start. How do you start talking about this? So, but like I say, that was when we started with that. It was probably mid 90s, and so that was a long time ago, and nobody was really talking about that. And they treated most people, even when they were children, as they didn't really know to call them substance use disorder, or they didn't have a label. They treated them as mental health, and that wasn't necessarily where they would maybe swap their cocktail of prescriptions for what they were already on, and that was not successful at all.
Dale, I'm curious, what's your interaction like with? Do you deal with people who are trying to recover or are impacted by this who don't go to the gym, or is it mostly all through the gym?
Primarily, so we do classes. We're contracted to a couple local treatment centers, and we do classes at their facilities. So we get to know the clients, for however long they're in inpatient or outpatient treatment. And then from there, if there's any opportunities I have available for employment, I'll take guys and try to give them part-time employment here. So we're always kind of in the loop. But they're in treatment, whether inpatient or outpatient. But unfortunately, a lot of those guys kind of go in and out of whether through relapse or whatever different reasons. But it is rough. One of the good things from the film is, you'll kind of see somebody go through a relapse, and so I will get, to Lisa's point is, when somebody relapses, people just are rightfully so focused on them, but they don't understand what the family goes through.
Right.
And God bless the parents who just feel hopeless. Because now, you could be in the case of my friend, he was in his 30s. And you can't just go get him and force him to treatment. It doesn't work that way. So then the question becomes, hey, as a spouse, as a loved one, as a family member, what can I do? And, there's no real good answer, especially when it's kind of up to that person. But, what I tell people is, hey, listen, the best thing that can happen is that person goes to treatment. Second best is they go to jail. Third is they're likely to die, just kind of based upon what's on the street. So you need to live your life in that relationship as this could be the last day you see them. And it needs to be non-judgmental. They need to know, whether through text or phone call, every day you send them a message and you tell them you love them, and that when they're ready, you'll drop whatever you're doing to go get them into treatment.
Yeah. And what are some of? Do you mostly guys, or is it men and women? And what's kind of age? Is
Both.
it kind of everything?
For us, it's I would say the normal. If I had to pick an avatar client, it'd be probably late 20s here. So both men and women. So yeah, primarily young adult. Although there's some people in their 40s and 50s as well.
Yeah. And Regina, going back to the caregiver role in recovery, and what can we do to help them, the caregivers, in this, coming from like either the federal government or just in general?
Yeah, so I think, what you've heard is a lot. I mean, there's no other disease for which you'd like, I'm going to call a guy because they might know where I can get help. And so, the efforts have been made, as Lisa mentioned. Alabama has a treatment finder. The federal government has a treatment finder. There are supports for parents. The Partnership to End Addiction has support for parents to help them find treatment for their child. The role of, parental support, caregiver support, I think that's somewhat new in terms of how do you provide support to them. The closest that, I mean, there's some work being done in law enforcement agencies around the country to deal with, the trauma that law enforcement might be addressing because they may have reversed overdoses repeatedly with naloxone. I think the mental health care for people who are caregivers is really unaddressed in many cases. There are peer support workers. So we have, AANA, that there was more informal support networks, obviously very effective over a long period of time. But now we have that formalized, professionalized with peer support workers, all of whom also, they're people with lived experience. They also need, mental health care and support for themselves as they're going through. So that's something that, it has to be part of any peer support network. There are peers that work in for people who are reentering communities. There are peers who work in emergency departments who can help connect people and the families to the help that they need. And that's kind of in the last 15 years, probably a relatively new aspect of the continuum of care for people.
Yeah. Dale, one thing you've mentioned that I'm kind of curious on, it's that getting back into the workforce. Can you talk a little bit about both what you're seeing and what you guys do at the gym as well? Because I feel like, especially in rural communities, we have a small workforce issue already. There's not a lot of people, or we need more employees all across the country. And so what are you seeing? What can we do to improve too?
Yeah, I mean, we're Portsmouth, Ohio has a town of 20,000 people in the tri-state area of Ohio, Kentucky, West Virginia. There are a lot of people out there. The problem is getting them, taking them from a societal liability into a tax-paying asset. And there's a couple ways to do that, but we just need to understand that, Medicaid might reimburse 90 days of treatment. That doesn't mean that person is going to be a candidate for long-term recovery. I take kind of everything back to the military example, but when you're done with basic training, that doesn't make you a soldier. So you need to get to your unit. You need to be assigned, follow on mentorship, more training to get to where you need to be. So for us, like my own 3 small businesses, they're all different aspects. But the cool thing is we're kind of partnered with the local treatment agency, and our employees sign a release of information. So to continue to have outpatient treatment and get kind of rent subsidized housing, they need to attend all their mandatory counseling sessions and be drug screened 3 times a week. So that gives me a good deal of comfort as the employee. And then my role is just to understand that that person's recovery comes first, and I need to create a flexible work environment for them. So instead of one person working 40 hours a week, I probably need to get 2 people working 20 and have them go on different shifts. So it is you are asking an employer to take on a much higher liability, if you will, but the return is like the guys and the people who work for me are entirely grateful. Like I've never seen so much gratitude by an individual that by giving them a shot. And it's not going to work out. You're not going to have 100% success rate. But the good thing is about having a workforce that's primarily made up of those in recovery. They are on the early signs more than anyone else will be. So you can kind of interdict and step in before anybody else can to ensure that, hey, maybe this is too much for you. Maybe we need to get you more in intensive treatment. But there's ways out of it. We just have to understand that this person is going to need a longer runway to kind of get them to set them up for success. You can't expect them to be a normal candidate right off the street.
Yeah. Lisa, do you see similar things like as how to get from recovery into the workforce?
Yeah, that's primarily what our mission statement is we work very hard on the recovery to workforce piece. So in our community, one of the first things we did was meet and greet with all of the local. We have a lot of smaller manufacturing companies in Fayette, and they're obviously needing workers. So we partner with some great companies there, and our guys wind up getting really good jobs. The guys coming to us have already had a good stretch of sobriety, so they're ready for that next step. But another piece we haven't talked about are like drug courts. So a lot of our people they've got to go to drug court. So, that's going to take you away from work, and your color comes up and you've got to go and do this. We've got to do a better job of coordinating that. We use a company that allows our participants to do their drug testing on a screen, just like we're on. It's a saliva test. And they're able to take that test and get the immediate results, which is amazing. So it's just we'll be able to send it in and get the results back. But doing those kind of things that gives the guys kind of a dignity that I've got to leave work because I got to go to drug court. And if they're not in a total recovery workforce environment like our guys are not, they're mixed in with other people, that becomes a stigma. All of a sudden oh, he's got drug issues. But just very grateful for the partnerships we have developed and are continuing to develop. Our guys are getting promotions because we're taking them to work, we're picking them up, we're drug testing them at our facility, so they know that they're getting good quality workers. We have what we call like an entry level job that we have a wonderful company that'll let our guys come in, and it's hard labor work, but then they know that maybe I don't want to do this, and that there's other jobs. So we try to tailor it best we can with the interests that they have. And we also partner with community colleges. I think that's a huge step for a lot of our participants. Don't even have their GED, so they've dropped out of school, 8th grade. So you want to be able to encourage that education piece so they can get that better job, because they've shown that they've gone and gotten their GED. Now they're going to go to a local community college and maybe get some training and be able to do that job that's going to pay them more. There's a lot of obstacles. One of our mission statements is breaking the barriers and the bubble of recovery. And we've already mentioned the bubble, and that's so very true. You can get caught up in your recovery, which is wonderful. But then when you leave, what are you going to do? What's your next step? How am I going to be able to send money to my kids? How am I going to be able to do that if I'm going to make $10 an hour? So we try to really provide those good paying jobs, but that is partnerships in your community. That is awareness through your drug courts, and people like us doing nonprofits willing to provide that space. So all those things working together, we're making great headway, but there's still lots of room to cover.
Yeah, that's great. Regina, what are you seeing kind of the trends nationally as what we can be doing again from recovery to workforce?
So, I'm sorry, I might have been, my computer broke up a little bit, but I'm going I want to talk about recovery ready workplaces. So the state Perfect. Of New Hampshire, very rural state, had a big problem, and this was several years ago under Governor Sununu, had a big problem with finding employees, and also had a big opioid use disorder problem in the state. So they created a recovery ready workplace program, and they work with employers to provide them the support that they need to do exactly what was just said, to provide people with accommodations where necessary, and, build success, help them create successful employee relationships, but also help address some of the stigma in the workplace. So build support systems for employers and employees, as well as their fellow employees. So there isn't that resentment, oh, this person's getting half the week off, so I've got to fill in for him or her. So, those recovery-ready workplaces are in several places around the country now. There's also, Kentucky has really expanded it as well, recovery-ready workplaces as well as recovery-ready communities. And these communities kind of make a commitment that they're going to do like X number of things, and they get, called a recovery ready community, recovery ready workplace. But it's really a lot of what was just identified as making sure that we can, get employees. That's a really important part of recovery is a job. So helping them succeed in those so they can be retained in their positions. There were some federal grants that were sent to states to help them set this up. There's some credit. Some states have tax credit programs for employers who hire people in recovery. But it's more than just giving them the job. It's also helping make sure that they can be successful.
Mm-hmm. That's great. I think as we wind down our conversation here, one of the things I want to talk about is prevention and overdose prevention. So what are the things that we need to be doing to the best we can to from your point of view, that we should do to prevent, to help with prevention? Dale, do you want to lead us off?
Yeah, I mean, it really just kind of depends on where an individual is that would be most acceptable to either first time using or relapse or any of that stuff. So kind of categorize where they are and develop a strategy best tailored for prevention for that. But for our guys, we keep going back to the community piece is, if you're on a team with somebody, that team is going to notice the signs first when you are going through outside stressors or potentially navigating a bunch of triggers that might cause you to relapse. So you need to really kind of surround yourself in a loving, caring, and compassionate community, and strengthen them with the ability to kind of step in and make this a community effort to go save people is really what it comes down to. So education and awareness will go a long way.
How about you, Lisa?
Well, I go back to the early prevention in our schools. I think that's going to be key across the country. We've got to get better resources and programming in our schools. You go back from in like the 70s when there were a lot of the drugs were super heavy then, and we just, say no to drugs. That was a big campaign across the country. And it was good, and I'm sure it made a difference. But I think that we have come a long way in being able to provide better prevention services, curriculum, whichever it is, or both. I think in the younger age kids, they just need to know a little bit more about it. And the older, I think that's when you can do more hands-on activities and learning and understanding and awareness. And in Birmingham, we have this big addiction prevention walk, and it's very moving. So people come from all over the state, and they just do this walk, and people share success stories, and they've gotten into our schools and done some of their curriculum. And I see a benefit from that, and I think that it can just be expanded.
Wonderful. Regina?
Yeah, so I think there are a couple things. One is that I think it's an assumption for those of us who are parents that our kids don't listen to us, which they don't always, but they do listen to you when you talk to them about substance use and what is, the risks of substance use. I'm very concerned about, increasing rates of overdose death among adolescents, 14 to 18-year-olds who aren't individuals who've had, long-term substance use. They're not necessarily using, they're purchasing it over the internet. They think it might be something that's going to help with their mental health. So that's something for parents to monitor and warn their kids about the risks associated with that. But also just to, the vast majority of kids, believe it or not, don't actually use illegal drugs, tobacco, or alcohol. It is not necessarily a rite of passage. Yes, kids are risk takers in many cases, but talk to your kids about using substances and the risks associated with them. But also the other piece is addressing those societal conditions, poverty, trauma, adverse childhood experiences that put a young person at greater risk for a substance use disorder. So making sure we're looking at how to build communities that can support families to build healthy kids with long-term health outcomes. And then on overdose prevention, just making sure that we continue to expand access to naloxone, the opioid antidote overdose, that it works to reduce overdoses. So we need to get that out there as much as possible.
What gives you hope? This goes to everybody. I'll start with you, though, Regina. Like, what gives you hope?
I'm always just really encouraged when I hear stories about, people saying, hey, this is a problem. It's all of our responsibility to do something about this. We can't just say it's somebody else, like point the finger at the government and say, you need to do something more. All of us need to do something. So what gives me hope is the fact that when I first started working on this, there weren't a lot of people doing much. It was really hard to get media attention, really hard to get anyone's attention on this. So the hope lie then in people taking charge and building the solutions at the ground level. And that's really what gives me hope right now.
Yeah. How about you, Lisa? What gives you hope?
What gives me hope are forums like this, that we're able to come together from across the country. Thank goodness for Zoom, that we can produce all this and put it out on social media. And then, believe it or not, I'm not a huge social media person, but the ability of social media to be able to share your stories. That's where when we go on Capitol Hill to lobby for legislation, and we're talking about what we're doing at the Will Bright Foundation, and we can share those stories with our local congressmen and senators, that gets attention, and that allows you to just have hope that whatever you're doing through the countless, Dale, how it is when you run a nonprofit and you're doing all the things, and it's a dangerous line of work, and you want to look for that hope, and the hope is in the residents, in the participants that are working hard and staying sober and going to work and trying to provide for their family. So that gives us hope in this world of addiction, that we have resources to be able to share the stories, the good and the bad, and get that knowledge out there.
That's great. Yeah. Dale, how about you? What gives you hope in this?
Yeah. Watching somebody come off probation, watching somebody open a bank account, watching somebody get their first apartment, seeing the first child they had outside of active addiction. It is a heartbreaking line of work to be in. You're inundated with 100,000 plus people dying a year. But there are those stories out there. People do recover. And I think more importantly is just, we're all collectively trying to push down that first big domino. And if we can, the others will fall.
Yeah, that's great. Regina, I know you put something in the chat, the paper you mentioned. Could you let folks know what you're working on and where to find your work?
Sure. So we put out, we talked to a lot of people from across the spectrum. We put out documents called Big Ideas, and as well as quick takes on opioid litigation spending. We have some quick takes about best practices that we recommend. So we are at o'neill.law.georgetown.edu. And you can just just type in addiction into there, and you'll see all of our materials that we try to make really accessible. And we do have some, peer-reviewed journal articles, but we have a lot on recovery-ready workplaces. We have, a lot on supporting people in recovery. So, folks are welcome to peruse our materials at o'neill.law.georgetown.
That's great. Thank you. And Lisa, where can folks find what you're doing and your work?
Yes, our website is the Will Bright Foundation, not the willbrightfoundation.com. We're on Facebook and LinkedIn as well. happy to share any of our stories, resources, how we've come from absolutely nothing to being up on the hill. So it's been a long journey along the way, but God has blessed every step.
That's amazing. And Dale, where can folks find your work?
Yeah, the documentary is available on Amazon Prime right now. Or the website for it is smalltownstrong.com, smalltownstrongdoc.com. And then at daleking.740 on Instagram if anyone would like to reach out to me personally.
Dale0 at, what was it? What was the
Sorry.
last one? No, you're good. I just, so I can remember.
Daleking.740. That's my area code.
Oh, nice. I'm 712. So.
Oh, there you go.
Not too far out. So I guess one last question, Dale. How much do you bench? I was going to ask Lisa first, but I thought I would ask you.
No, you don't want to ask me.
Not enough, man. Never enough.
Yeah.
Never enough.
No, I used to play professional baseball, so like I work out quite a bit, but I'm 6'6" and got long arms. I'm not strong at all, though. So no, I can't thank you all enough for what you do, this conversation, and thank you for taking your time out to share your wealth of knowledge and your experience with us today. Thank you, Lisa. Thank you, Dale. Thank you, Regina, for all that you do.
Thank you. Appreciate the honor of being able to come on. I'm gonna grab a quick selfie too, so I can post it on my socials.
Perfect.
Thank you all.
Take care.